Good evening, everyone. Welcome to today's webinar of the Young Internists of EFIM. My name is Johanna Brägelmann. I'm a young doctor from Germany working in the field of endocrinology, and I'm very happy to moderate today's webinar about the perioperative management of patients with endocrinopathies. And we will focus on two quite common endocrinopathies. So we will start with diabetes mellitus, and we will move on with adrenal insufficiency. So I would like to introduce Dr. Jan Skrha from the Charles University and General Hospital of Prague, Czech Republic. Thank you for coming.
Yeah, hi. Thank you very much for introduction. Dear colleagues, dear friends, it's my pleasure to be the part of this Young Internist webinar. And it's also a pleasure that diabetes is a part of this endocrinopathies, because I think it's a very important part of management of patients in our hospital. I hope that you can see the slides and the presentation. Yes, okay. So let's start with this discussion about diabetes. I'm sure that you are quite familiar with all the new medication, and I think that diabetology really has changed pretty much in the last 10, 15 years because of many new drug classes. And of course, we like that we have quite enough stuff how to treat, but sometimes the management can be a little bit tricky. We have a lot of new insulins, we have a lot of new non-insulin injectables, and for sure you also have several patients on diabetes technology. And if something is really a huge difference and huge progress, then technology with insulin pumps and glucose sensors is something what's really incredible. And on the other hand, it can be a little bit tricky in hospital, especially if the patient undergoes surgery. And we will discuss this topic. Don't worry about all these new gadgets and new medication, because all in all, it's quite simple. Well, I will speak just a little bit about the importance of diabetes and the management of diabetes in this perioperative surgery. We will speak about glucose targets of diabetes, and we'll also speak about the medication and what to do prior to surgery and how to adjust the medication, both non-insulin agents and also about insulin. What is quite clear that the surgery is very much dependent, and the quality and the success of the surgery is very much dependent on diabetes control, and it can be expressed either by glycemia or glycated hemoglobin. Doesn't make the difference. And we have a lot of data showing that the worse diabetes control is, the worse is the morbidity and mortality of patients with diabetes after the surgery. So we should really take care of each patient with diabetes, and we should focus on his or her control. It's quite clear that the higher HbA1c, which reflects worse diabetes control, is not good for the mortality. And you see here, this is the J or U-shaped curve, and high HbA1c definitely brings higher risk of mortality, both in patients on insulin, but also on non-insulin agents. But what's quite interesting, that if the HbA1c is really low, the risk is again higher. And I think that we have to take this into account, because this means that there is high risk of hypoglycemia. And hypoglycemia is pretty bad for people with diabetes in the perioperative period. So what's our task if we are physicians in hospital preparing our patients with diabetes for surgery? We should make our best to do optimal hydration, mineral balance. It's quite clear. But we should, at the first place, we should avoid hypoglycemia. I have discussed already. And also severe hyperglycemia can be problematic. And of course, diabetic ketoacidosis is something what's definitely wrong in people undergoing any kind of surgery. You know that every patient before surgery is classified according to ASA risk score. And I'd like to mention that also well-controlled patient with diabetes is directly in the group ASA2, in the category ASA2. And if the control is not perfect or there are complications, there are hypoglycemias, the patient directly jumps into ASA3 category, which is a problem. And we should take really a huge control in a patient with this kind of diabetes. But let's move a little bit earlier, before the hospitalization. What should be assessed in every patient with diabetes? Definitely, we should know about his or her diabetes control, which means what is the glycemia, what are the glycemic profiles, what is HbA1c, glycated hemoglobin as a marker of long-term or middle-term diabetes control. This should be done in every patient undergoing any kind of surgery. But of course, in people undergoing larger surgery, we should know about kidney functions, about livers, about other proteins, coagulation, etc. And of course, depending on the precise type of surgery, another examinations are also needed. What's important to know is the validity of our examination. And if the patient is not risky enough from the ASA2 category, 2 weeks prior to surgery is enough, and there is nothing, anything else necessary to do. But if the patient is more risky from category ASA3 or ASA3 to 4, it should be done just prior to hospitalization or just prior to the surgery. It's easy to do it directly in hospital. There is a very nice diagram or scheme for the first reflection of the specific patient with diabetes. It was made by the French anesthesiologist, and I think this is very useful. And you see from the HbA1c directly whether the patient is categorized as really eligible for surgery, if HbA1c is from 6 to 8%, or if you prefer millimoles per mole, then 42 to 64 approximately. And it's quite clear that if the control is not good, we discussed already this situation, if there are a lot of hyperglycemia, the medication should be changed or adjusted. But what's also important, again, the opposite problem. If it's too low in HbA1c, it means that there are hypoglycemias, and if it's really severe, the surgery should be postponed. So please take this into account, because this is, I think, very easy and very good for our clinical practice. If we think about our individual patient, whether to send him or her directly to surgery, or whether it's better to postpone it. The first assessment should be done 2 to 4 weeks prior to surgery, if we have time for this. And we already discussed the good values of HbA1c, which are eligible for the patient to undergo surgery. Of course, if it's not in this region, we should do some changes in the management of diabetes. We should consult endocrinologist or diabetologist according to your local settings, and we should prepare the patient. However, there are specific situations where the surgery should not be postponed, and of course, especially in patients with tumors, in patients with sepsis or inflammations, where the surgery is necessary to direct treatment, then it's necessary to do it directly. That's quite clear. So let's come to the time of surgery. Let's go to hospital and we have our patient, and we should think about targets, glycemic targets in hospital. And it's always about a balance, because on one hand, we would prefer strict control, but on the other hand, we know that in strict control, the risk of hypoglycemia definitely increases. So that's why we should look for some safe target. And I will show you current recommendations for these targets just in the following slide. There is a very nice initiative in EFIM, which is critical appraisal of various guidelines. There were a lot of several guidelines on pulmonary embolism, on echocardiography and other. And last week, there was published a new guidelines on hyperglycemia and treatment of hyperglycemia in patients who are hospitalized. And it was my privilege to be the part of this working group and prepare these guidelines, which were published in EGIM. And this was done as a critical appraisal of current guidelines, international, American, European, etc. And we prepared these practical recommendations for colleagues in internal wards around the world. And have a look at the middle part of the table. These are the glycemia targets for patients in hospital. And you see that these targets are not so strict. Definitely for people who are critically ill, these targets are quite benevolent and slightly relaxed to avoid hypoglycemia. In perioperative period, if the patient is on ICU and perfectly controlled, we can go a little bit lower with glycemia, but firstly, we should try to avoid hypoglycemia, which is the message. Of course, in people who are chronically poor controlled with diabetes, who are very old, who have hypoglycemias pretty often, we should keep higher targets. We should be not so strict, and vice versa. If our patient is young and very compliant with the medication, with the treatment, and if he or she has perfect control, then also in hospital we can keep the stricter targets for glycemia and glycemic profiles. So, how to change the medication, or is it necessary? Not always. If the patient is perfectly controlled, there is no necessity to change anything specific in the treatment of diabetes. Sometimes we have to switch to intensive insulin treatment, or the profile to go over the surgery. It can be temporary or it can be for a longer time. It really depends, but we should prepare the patient for the targets in glycemia. Let's have a look on a busy table, and I'm sorry for this, but I think it's very nice and very practical. How is it with the oral or non-insulin anti-diabetic medication? How to withdraw it, or how to omit it before surgery? And to be honest, it's quite easy, because in most people, it's not necessary to avoid most of the medication. You know for sure about metformin, and according to the current guidelines, if the patient is good in his or her renal functions, then it's not necessary to omit metformin in advance, just in the day of surgery. But of course, if the glomerular filtration is going down, it's good to withdraw it earlier. Nowadays, what is the most important message from this slide is the situation with gliflozins. SGLT2 inhibitors are widely spread nowadays. We use it for diabetes, we use it for heart failure, we use it for kidney disease. And according to recent guidelines, it's recommended to omit gliflozins 3 days prior to surgery. And we should really try to keep this recommendation because it's recommended to prevent from euglycemic ketoacidosis. This is a rare complication. However, it can happen and it can be quite dangerous for the patient without hyperglycemia. So it's sometimes tricky to think about this complication. And if it's possible, it's good to withdraw gliflozin really in advance. And another interesting situation is with the GLP-1 receptor agonist. For sure, you have heard about the situation last year or 2023 when American anesthesiologists warned that there is a higher risk of aspiration during intubation in this perioperative period in people using GLP-1 receptor agonists. There were several discussions whether this is really so important message. And according to these recommendations, we should omit the last dose of GLP-1 receptor agonist prior to surgery. However, you know that most of the modern GLP-1 receptor agonists are used once weekly, which means we should probably omit the last application almost 1 week before the surgery, with what is sometimes not really kept. So we should really think about this. There are a lot of discussions whether this is necessary in all patients. There are data showing that people who are on this medication for a longer time and who are already used for this medication, the risk of aspiration is much lower. So maybe it will be slightly different in the following guidelines, but nowadays this is up-to-date topic. How is it with insulins? In general, it's quite easy. The recommendation is reduce the dose of basal insulin to approximately 80% of the normal dose. Whether the basal is given the day before, in the evening, or in the morning of the surgery, still the reduction should be approximately to 80%, which is easy and which can be kept quite easily. And it's good for the patient because how to do it with the insulin delivery during the surgery? There are, again, some changes. The best recommendation is just to modify the chronic medication, which means just modify the dose of basal insulin if the patient is already on insulin. Even in specific situations, maybe you know from the older recommendations to give some infusion of dextrose with potassium and insulin. Of course, for critically ill patients or decontrolled patients, there is still the sliding scale recommendation to use insulin via perfuser and to infuse some infusions. This is good, but it can be a little bit tricky. It needs a lot of action by the nurses or by the physicians around the surgery. And it's also more risky for hypoglycemia. So this is just for some specific patients. The majority of patients should be just modified on their chronic anti-diabetic medication. Well, how is it with insulin pumps? Again, a very nice topic because insulin pumps has pretty much changed in the last years. And nowadays, it is recommended that we can use insulin pumps during surgery, but we have to be educated. Not only the patient, but also the staff have to be educated. And what's also important to mention that, of course, the pump is not allowed if the patient undergoes some X-ray or CT during the surgery. Then we have to remove it. However, in other situations, insulin pump can be used. Again, we should set some reduction of the basal rate of insulin during the surgery. And what is a very important message is about the use of CGM, continuous glucose monitoring in the time of surgery. I will discuss it in the next slide. And there is one very easy recommendation: start on insulin pump. But if anything goes wrong or not really controlled, just remove the pump and switch to IV administration of insulin as you are used to. So definitely this is always possible to switch also during the surgery. I've already mentioned CGM. Continuous glucose monitoring has changed pretty much in the last years. And these systems are great for our patients with diabetes, especially for the outpatient settings. But there is a huge research on using CGM in hospital as well. And the latest guidelines or recommendations, it's from the American Diabetes Association and the standards of care from 2024, for the first time, really recommend using both CGM and also the pumps, which are automated or semi-automated according to the data from CGM. And this can be really beneficial for patients also during hospitalization. However, again, several considerations. It must be clinically appropriate. It must be checked with point of care glucose measurements, glucometers sometimes. And of course, the staff has to be trained. And of course, it has to be according to the protocol of each hospital. So nowadays, it's already allowed to use it. However, not for the surgery. We should keep into mind that during the surgery, there can be some centralization of the circulation. There can be hypoperfusion of the skin. And in such situation, the data from the sensors are not really precise and therefore could be wrong. Afterwards, the treatment with insulin could be quite wrong. So still, CGM during the surgery not routinely be used. How is it with the infusions around surgery? Maybe it's not the most important topic. It depends to standards or protocols of each hospital. And there are several combinations. There are also some premix solutions. And I think that we still have to use what we have in our hospitals, and we should monitor and measure each patient, and we can adjust it according to this. So to conclude, I think that everybody really knows that the management of people with diabetes is very important in this perioperative period, because it can pretty much influence the quality of the surgery. It can also reduce the length of hospitalization, which is important not only for the patient, but also from the cost view. And on the other hand, we should take into account that all guidelines and all recommendations are just for the general population, or maybe general diabetic population, and each specific patient is individual, and therefore not all the guidelines are applicable for each patient. We should really modify it according to the specific situations. Thank you very much for your attention. I think that you will be not really worried about your patients if they have diabetes. And especially if we are internists, it's much easier than in the surgery operating room. So thank you very much for your attention, and hopefully there will be some questions.
Yeah, thank you very much, Jan, for this very helpful overview about a very important topic, because we all treat patients with diabetes no matter on which ward we work on. So I think you gave a lot of helpful information. I would like to open up for discussion. So the audience is, I would like to encourage the audience to ask questions. Questions can be asked in this question and answer field, which works pretty much like a chat. And as we do not have questions until now, I would like to ask one or start asking questions. So you told us that you recommend to reduce the insulin to 80 or 100%, 80% if patients are on insulin already. Could you be a little bit more specific on the type 1 and type 2 diabetes patients?
It's a really good question. I think this is not really too much dependent on the type of diabetes. If patients with type 2 diabetes are insulin dependent, then again, the necessity for some basal insulin is almost the same. So I would do quite similar reduction both in type 2 and in type 1 diabetes. Of course, if the patient is critically ill and or the surgery is done in non-standard setting, still we have to switch to the sliding scale regimen of delivering insulin by perfuser. In such situation, the basal insulin subcutaneously administered is not the best option. So this recommendation for reduction of basal insulin is for stable patients who go from let's say internal ward to the surgery and then pretty early back. If the surgery is huge with some view of several days of staying on ICU or surgery ICU, then definitely such patient requires the sliding scale and insulin intravenously by perfuser.
Okay, thank you. Now we also have one question from the question and answer field from Asmatullah Sapand. He wants to know the indications of the sliding scale application of the insulin. If you could be a little bit more specific on when to apply the sliding scale and when not to.
I think that there is another easy way how to say just now switch to sliding scale. It's very much dependent on the protocols of local hospitals, and I see also in the Czech Republic there are huge differences among hospitals. Sometimes they really try to switch almost every patient on insulin to sliding scale, which is definitely not the best way, and I think it's useless. However, if we feel that the patient could be problematic or complicated, then it's indicated to switch to sliding scale. Definitely, if it's patient with type 1 diabetes and there is some suspicion for several days of fasting, for example, after the surgery, definitely a sliding scale is good way. I think that the message is more that we should not be worried about using just basal insulin subcutaneously in stable patients. This is the message because it was not the case several years ago, and this has really changed. And also, anesthesiologists really try to change their minds in this way, and I think it's good.
Okay, perfect. I would just like to ask, maybe, do you feel like in your hospital that people working in surgery are comfortable with these kind of diabetes handling strategies, or are there a lot of insecurities and then they call you?
Sure, they are not really familiar. They do not like it at all, of course. It's another complication as compared to people without diabetes. That's true. But on the other hand, most of the management is performed by anesthesiologists, which is, I think, quite good way how to bridge this problem with surgeons, which is quite normal. I think that they really think slightly differently about patients and about caring and treatment of this kind of problems such as glycemia. So it's good to push it to anesthesiologists, which are, I think, quite familiar with this kind of treatment, especially most of the anesthesiologists.
Okay. So until now, there are no more questions in the question and answer. Oh, there's one more. Yeah, it's just a thank you for your very interesting presentation and for the whole team. So thank you for that comment. Then we would, or I would like to go on with the second presentation. If there will be other questions coming up about diabetes, Jan will stay here and we can discuss this later as well. So the second presentation is about the perioperative management of patients with adrenal insufficiency. It's a very important topic as well, but not so common. So to my experience, people who are not working in endocrinology are sometimes not very familiar with handling adrenal insufficiency. So I hope that the next speaker, Dr. Zora Lazúrová from the Czech University and University Hospital of Košice in Slovakia, will help us to do it better.
Thank you very much. Thank you. Good evening, ladies and gentlemen. I just hope you do see my screen. In case if not, just please tell me. I would focus on the perioperative management of the adrenal insufficiency, like another endocrinopathy. At the beginning, I would start with the data we are not very happy about. It's been found that in UK, more than 8% of all patients with known adrenal insufficiency experienced an adrenal crisis during a hospital stay of other cause, just due to inappropriate management by a medical staff. So this is not very nice data. So we still have some things we have to improve. So in this presentation, I would focus on the management of adrenal insufficiency patients and how to avoid the adrenal crisis in these patients. So the most common cause of adrenal insufficiency is the tertiary form, the central form, is actually iatrogenic form caused by the suppression of adrenocortical axis, which is caused by the long glucocorticoid treatment. It's the most common cause. Then from the peripheral primary types, the most common is autoimmune adrenalitis, which is known as Addison's disease. Here you can see also the other causes, and all patients with adrenal insufficiency has to be on a substitution treatment. If it's central peripheral, all patients need glucocorticoid substitution, while the most commonly used and most physiological is hydrocortisone in 2 or 3 daily doses, approximately in 15 to 25 milligrams a day. In case of peripheral forms, also the minor mineral corticoid substitution is needed. So the main regulator of cortisol secretion is the stress. And the standard condition, the daily cortisol production is about 5 to 10 milligrams per square meter of a body surface, which is equivalent to approximately 5 to 7 milligrams of prednisone or 20 to 30 milligrams of hydrocortisone. And as you know, the highest levels of cortisol are in the morning time with the depression during the midnight. But during the stress, physical or mental stress, there is 5 to 10 times increase in production of cortisol with a loss of diurnal rhythm. After the end of the stress insult, the normalization levels normalization of the levels are within 1 or 2 days approximately. And as we know, the operation is also a big stress for the patient. Therefore, these patients need a specific approach in the perioperative period. And to classify and to somehow stratify the operation stress, we use the Johns Hopkins classification. So the surgical procedure or the invasive procedure is classified to 3 groups. First one, grade 1, the minor operation stress, are relatively small procedures with a small blood loss, and it presents like small skin procedures, biopsies, gastroscopies, colonoscopies, small gynecological interventions. Here the patients have, as you can see on the graph, none or just insignificant peak of the cortisol, and the total increase in production of the cortisol is approximately 2 times within the first 24 hours. Then it gets to the normal. In the second grade, moderate operation stress, these are interventions like laparoscopies, hysterectomies, orthopedic interventions. Here the peak of the cortisol is at the time of extubation, and the normalization of cortisol levels becomes usually after 24 hours. The total increase in the cortisol production is about 3 to 4 times increase. And the third grade, the biggest, largest invasive procedures like cardiosurgery, neurosurgery, big GIT operations, or thoracic surgery. In these cases, the peak of cortisol levels is after between 6 and 18 hours, and this peak persists for a day. The normalization of the levels within 5 to 7 days. So patients with adrenal insufficiency it's been found they have higher risk of perioperation complications and also the mortality. Even in this group of the patients, we identified some risk factors of perioperation instability. Patients with adrenocortical insufficiency of the primary cause, which have also the mineralocorticoid deficiency, they are in a higher risk of perioperation instability. Also, the patients with adrenal insufficiency who have also asthma bronchiale, obesity, or concomitant medication inducing activity of cytochromes may worsen the perioperative period in these patients. So the substitution during the operation and pre and post-operative period is very important, and it's specific. All procedures in general anesthesia have to start with 100 milligrams of hydrocortisone as intravenous bolus before the induction of the anesthesia. And right after, according to the guidelines, you should continue with a continuous infusion of 200 milligrams of hydrocortisone for 24 hours. If it's not possible to use continuous infusion, you can also use smaller doses, 50 milligrams of hydrocortisone every 6 hours. But here it's preferred to use intramuscular injection before intravenous, since the reabsorption of hydrocortisone from the muscles is slower and it doesn't produce the peaks. If you use intravenous form, the half time is maybe 2 hours or 3 hours to make just 4 big peaks of cortisol levels. So it's not very physiological. After restoration of peroral intake in patients undergoing operations of grade 1 or grade 2, you have to double the doses of chronic peroral hydrocortisone treatment for another 2 days. In case of patients undergoing the grade 3 operations, you have to use this in double doses for another 7 days. In case of complications or patient doesn't have an peroral intake, you have to continue in parenteral substitution of hydrocortisone in the dose of 200 milligrams daily. You can also, it's acceptable to use also dexamethasone as a substitution in this dose, but it's applicable only in central form because dexamethasone doesn't have mineralocorticoid effect. So for primary peripheral adrenal insufficiency, it's not enough. In case if we have a procedures without anesthesia or they are in local anesthesia, here we have to administer 100 milligrams of hydrocortisone right before the procedure. And for the next 24 hours, patients should take in double doses of chronic peroral substitution treatment. Colonoscopy is a specific examination because not only the examination, the procedure is a stress, but also the preparation before is stressful for the patient. So it needs a specific approach. If we have a patient with adrenal insufficiency, which is prepared out as an outpatient, 24 hours before the procedure, you should use double doses of hydrocortisone perorally. In case of high-risk patients, mostly patients with primary form of adrenal insufficiency, which are more risky, it's preferred to prepare them in hospital. So in this case, it's better to substitute hydrocortisone parenterally in these small doses, 25 to 50 milligrams every 6 hours. And also be careful about the IV fluids. A specific situation is also the management of a pregnant patient with adrenal insufficiency. Since 20th week of pregnancy, we should increase the hydrocortisone doses in about 10 milligrams a day. Right before the labor, 100 milligrams of hydrocortisone should be administered, and it should be followed by infusion of 200 milligrams for 24 hours. After non-complicated labor, you can switch the patient to peroral hydrocortisone in double doses for another 2 days. In case of cesarean section, you have to manage the patient as operation in general anesthesia. The second part of the lecture will be dedicated to actually the most common cause of hypocorticism, and it's a patients with iatrogenic suppression of hypothalamo-pituitary adrenal axis. Like I said at the beginning, it's the most common cause of hypocorticism, and it's been found that in some countries, even 7 or up to 10 patients in 1,000 of inhabitants use chronic glucocorticoid therapy, usually because of some anti-inflammatory indication or as a part of oncological treatment, etc. So the risk that you will see such a patient is quite high, and these patients also need specific approach in this perioperative period. If the patient is taking prednisone in the dose of 5 milligrams or other corticosteroid in equivalent dose for more than 4 weeks, patient is considered to have some kind of suppression of HPA axis. Also have to be aware about the local forms of glucocorticoids. The use of intraarticular injection of glucocorticoid or also inhalation may suppress the axis. For example, after intraarticular injection, 3 to 6 months, the HPA axis remain suppressed. Under standard conditions, patients do not have any symptoms, but when they have a stress operation, in these cases, even adrenal crisis or form of subclinical hypocorticism may manifest. And after the discontinuation of the treatment, the restoration of HPA axis, the duration is very, very various. In some patients, it lasts weeks, but in some patients who are long time treated, the restoration of HPA axis may last for a few years. Also, some factors have been identified which contribute to a suppression of HPA axis, and such as systemic treatment of glucocorticoids, of course, the higher the dose, and the high chance of suppression, the duration of the treatment, of course. Also, when you use corticoid with long effect, is more potent to suppress the axis when you use the evening dose or more doses during a day or treatment in repeated cycles. And when you have a patient which already has Cushingoid habitus, you have to consider this patient as hypocortical automatically. And how to manage these patients which use chronic corticosteroid therapy? First of all, do not discontinue corticosteroid treatment, because underdosing or discontinuation of the treatment may induce adrenal crisis or cardiovascular instability. On the other hand, the overdosing leads to hyperglycemia, hypertension, venous thromboembolism, the wound healing is decreased, higher chance of infections, and more perioperative complications. So if you have a patient who is undergoing operation in the Johns Hopkins classification grade 1, you have to leave the chronic dose of peroral glucocorticoid, or right before the operation, you have to administer 25 milligrams of hydrocortisone intravenously. After operation, after surgery, you continue in the chronic doses of chronic glucocorticoid treatment, whatever it was. In grade 2, you have to leave the daily corticosteroid dose, and before the operation administer 25 to 50 milligrams of hydrocortisone as a bolus, and continue in substitution of small doses for 24 hours or until the restoration of peroral intake. Then you have to continue in chronic corticosteroid therapy. In case of grade 3 operations with the highest invasivity, these patients should continue the daily corticosteroid dose with bolus of hydrocortisone before the operation, and continue with low dose substitution until you have the restoration of peroral intake. In case of some instability or not in peroral intake, you have to consider in lower doses like 50 milligrams of hydrocortisone every 6 hours until recovery, and then or continue in chronic doses. In some specific situations, you might have a patient who recently finished or discontinued the therapy of glucocorticoids less than 3-4 weeks before the operation. In this case, you have to consider how high was the dose and how long the treatment lasted, the duration of the treatment. So in case if the patient was taking prednisone in the dose of less than 5 milligrams, you don't have to do anything special. In case you have a patient who was taking high doses, so prednisone more than 20 milligrams or any other glucocorticoid in equivalent dose, more than 1 month, you have to automatically substitute the patient just like he has adrenal insufficiency. In case if the treatment by high doses glucocorticoid was shorter, less than 1 month, or it was a moderate dose. So prednisone 5 to 20 milligrams daily, or any other corticosteroid in this dose. And the treatment lasted more than 1 month. You have to test the activity of HPA axis. And how to test the activity. So first you have to, if it's a planned operation, you have a time, you have to measure the morning serum cortisol. If you have the serum cortisol less than 150 nanomole per liter, you have to manage the patient as adrenal, as a hypocortical patient. On the other hand, when the cortisol level is more than 300, there is no need for any substitution for any specific approach. If you have a cortisol level in between, in this gray zone, you have to do ACTH stimulation test. And that's actually a stimulating of adrenals by the cosintropine, so synthetic ACTH, either intravenously, intramuscularly, and measure cortisol 30 and 60 minutes after administration. If the cortisol increases for more than 450 nanomole per liter, it's normal physiological response. In case this cutoff is not reached, you have to manage the patient as a hypocorticism. And at the end, I would mention also a specific situation when you have a patient with a hypotension, fever, or some neurological symptoms in the perioperative period. Most of the surgeons, anesthesiologists, intensive care medical staff thinks about sepsis, bleeding, but these symptoms may also be in adrenal crisis. So you always have to consider in differential diagnostic process also the adrenal insufficiency. Even when you have hyperkalemia, hyponatremia, or hypoglycemia, they support this theory for this disease. Either could be a patient with known adrenal insufficiency, or it could be a patient with newly diagnosed adrenal insufficiency, which was manifested during the operation. And how to manage. So first of all, the IV fluids is important, either saline or glucose or the combination. And you have to substitute the hydrocortisone in high doses, so 100 milligrams as intravenous bolus plus 200 milligrams for 24 hours. Eventually, in some cases, you might use even higher doses according to clinical condition of the patient. And since the patient usually have hypotension or even a shock, the vasopressors are needed. The preferred one is norepinephrine. But you have to be aware if you have like a shock resistant for vasopressors for norepinephrine, you have to consider adrenal crisis, because norepinephrine without hydrocortisone is very, just a little bit effective. So at the end, I would just revise a few take-home messages. So I would want to focus and emphasize that inappropriate perioperative management of patients with adrenal insufficiency may be even fatal in some cases. So therefore, the increase in substitution of hydrocortisone have to be individual, and it should be managed according to the operation stress, which is classified by Johns Hopkins classification. What is more, you have to think also about HPA axis suppression in patients on a chronic treatment by glucocorticoids. And in these patients, just do not discontinue corticosteroid treatment before the operation. In some patients, the evaluation of HPA axis might be needed in the case of recent discontinuation of glucocorticoid therapy. That means every patient needs individual approach, and patients with adrenal insufficiency, it's not a rare disease, but despite this fact, we have still a lack of studies and guidelines in the perioperative management. These guidelines I presented were anesthesiology guidelines, not an internal medicine or endocrinology guidelines. So it needs an individual approach, every patient. So thank you for your attention.
Thank you very much, Zora, for that very interesting and comprehensive presentation about this very important topic. The number that you named just on the first slide was very alarming, that 8% in the UK suffer from adrenal crisis in the hospital. So I would like to ask, because prevention is usually better than intervention, so what would you do to prevent these kind of things? Do you have like emergency cards or emergency sets, or how do you educate the patients?
So first of all, patient has to be educated then also the medical staff has to be educated. Often when a patient with diabetes comes to the hospital, everybody has it marked as a diabetes, but sometimes we forget about adrenal insufficiency sometimes. So it should be a more maybe more promoted. We have to think more about these patients because it might be even more dangerous and more acutely dangerous than diabetes, because it takes some time until you decompensate. But in adrenal crisis, it's very rapid. In this case, and yes, as you said, the patient should be educated. Of course, sometimes the patient says to medical staff that I have this, and they are more wise than the medical staff. This happens sometimes, and yeah, they have cards. I think it's in international. All countries have this Addison cards. So we have it. We educate the patient for them. But these data from UK, it was mistake of medical staff. So I think it'd be more maybe promoted among doctors and also maybe nurses and the other medical staff.
And just for my interest, do you have some kind of central register in Slovakia or some kind of electrical patient record where you could see this information when you're a doctor in the hospital and the patient comes to the emergency unit? Or did you need the patient to tell you that he or she suffers from adrenal insufficiency?
Well, we have a register, but it's not available during a night shift everywhere. We have a list of all adrenal insufficiency patients, but it's not available that you can find out or find the patient somewhere. We have like electronic health records, but depends if the patient has already been somewhere in the hospital. If it's in the private outpatients, you don't see all this documentation. So in some cases, it might help you, but not in every patient. So you have to ask the patients anyway, actually.
Yeah. Okay, but at least that's better than in Germany. Okay, then we have some questions in the chat. Also, thank you to the audience for participating. The first question, I think, is already answered. Someone asks about how to diagnose adrenal insufficiency, whether the serum cortisol levels are enough. I think you answered that perfectly already. And if the one who asked that question has still questions, please just post it into the chat. Another question is about anesthetic drugs. And Asmatullah wants to know whether there are some drugs who can exacerbate adrenal insufficiency in anesthesia, for example.
Good question. In adrenal insufficiency, we are not that aware about anesthetics, just like in pheochromocytoma, for example. So I'm not really aware of any drug you should be avoided in patients with adrenal insufficiency. So no, in case of pheochromocytoma, yes, there are some restrictions, for example. But in terms of hypocorticism, actually no. There have been mentioned some medication which stimulates the activity of cytochrome, but anesthetics are not belonging to this group very much, at least to the best of my knowledge.
Okay. Thank you. Then there are two questions, actually more or less about the same topic, also a very practical question. What about patients with bronchial asthma and inhaled steroids? Would you treat them as patients who are potentially at risk having an adrenal insufficiency, or would you just let go because it's only topical or inhaled steroids?
Not just inhaled, because it might really be very effective in suppression. Depends on what kind of glucocorticoid it is, how long does the patient take it. So if it's there are these guidelines where you can find exact glucocorticoid, local, topical, and how potent it is. So for example, I think fluticasone is one of the most potent out of this inhalation. So if the patient is on a planned operation and is taking it longer, in this inhalation, we don't speak about months, but we speak about years usually. It's better to test the patient, at least this morning cortisol, because it might be decreased. So in urgent operation, it may depend on the clinical state, or just in case to cover the patient with hydrocortisone. But in longer lasting treatment and planned operation, I think it should be one of the part of pre-operation screening before the operation. And the most potent out of this topical is intra-articular. Like I said, these patients really have 3 to 6 months after injection. they have to be considered as hypocortical because almost all patients have suppressed HPA axis after intraarticular injections because the absorption of corticoid is extremely high, just like in intravenous administration.
Okay, so when in doubt, test for cortisol, right?
It's better. Actually, in the literature, it's been also written a case of adrenal crisis in a patient using not inhalation for asthma, just only nasal corticosteroids. So even this, it's extremely rare, but if it's long-term high doses, even this can suppress the HPA axis. I think no patient would even tell that I'm using some nose drops, but you have to ask.
Okay. Then we have another very interesting question. And the colleague who asks this question wants to know whether hydrocortisone is enough or whether you sometimes also need fludrocortisone or dexamethasone. On which patient needs what?
Yes, so usually every patient has to have glucocorticoid. We prefer hydrocortisone usually. In case of peripheral forms, the fluorocortisone is needed, but only in case for chronic treatment. If you have a perioperation strategy and adrenal crisis, the high doses of hydrocortisone, they have also mineralocorticoid effect, so you don't need to cover both. Hydrocortisone, if you have doses more than 50 milligrams daily, it covers mineralocorticoid need. If you're going lower, you have to add mineralocorticoid, but during these acute phases, when you use high doses intravenously, hydrocortisone is covering also mineralocorticoid needs.
Okay.
And dexamethasone, sorry, like I've said, it was only for the central form because it doesn't have mineralocorticoid effects.
Mm-hmm. Okay. Oh, there's another question coming. Okay, the last question is whether you recommend hydrocortisone during an operation of adrenal tumors, functional or adrenal incidentalloma. I think you answered that already, but maybe you can add something.
Definitely, yes, depends of what kind of tumor it is. And of course, if it's I don't know, Cushing syndrome, hypercortisolism, you have to cover, not only cover, but in high doses. In case of just unilateral operation, it's not needed always because if it's the second one is healthy, it's not suppressed, and one adrenal gland, it's enough for you to cover even the demands in the stress. So under standard conditions doesn't have to be, but in case if hypercortisolism or anything like this, you have to cover the patient.
Mm-hmm. Okay, one more question. So Santosh wants to know if the patient comes to the emergency room with adrenal crisis, with hypotension and hypoglycemia, what kind of inotropes and how much dextrose supplementation would you give, or how much would be required?
Still individual, because adrenal crisis, not every patient must be necessarily in the shock and unconscious. The patients, when there is the early phases of or developing the adrenal crisis, they are just weak and with a just little bit decreased blood pressure. So not every patient needs vasopressors right away. So IV fluids and hydrocortisone is a key factor. And then just to wait for the lab test for the clinical result. Of course, if it's too severe, they are in a shock, you have to use this norepinephrine, but together with hydrocortisone. Because like I've said, the resistant shock for vasopressors, for norepinephrine, it's a very high suspicion for adrenal crisis, even if you don't know that the patient has adrenal crisis. So because hydrocortisone actually mediates the effect of catecholamines in the vessels. So without hydrocortisone, the effect of catecholamines, it's not sufficient.
Okay. And then I would also like to ask one question. So we know now a lot about the management of adrenal crisis, especially in acute situations. And usually we have some idea that the patient deals with some kind of adrenal insufficiency or has some kind of disease in this field. But what would be a typical patient presenting with adrenal crisis where we do not know that he or she has adrenal crisis? So what would be like a physical state, and what would be some blood counts where you would assume that he or she could have adrenal crisis?
Like I said, adrenal crisis the clinical manifestation may vary. It might be just a patient who enters your emergency, walking and just explaining, I'm extremely weak, and the patients you see they are weak. You don't know what's with them, but you see they are not okay. Often they are pale, weak, and so, or it might be a patient almost unconscious, not able to move, and so. So it depends. It may vary. But when you see somebody in shock, you have to consider, okay, it might be also one of the rare causes, could be adrenal insufficiency. And these patients who came just because of weakness, sometimes it takes days until we made a diagnosis, because sometimes we don't know why. The muscle weakness, pre-syncopes, orthostatic hypotension. Sometimes the blood pressure might be normal when the patient is sitting or laying down, but the first manifestation is just orthostatic hypotension, for example. So in these not emergent cases, you have to do the blood test, and you don't have to have necessarily severe hyponatremia, hyperkalemia, and hypoglycemia, only when you see the cortisol levels decreased, in these severe cases, usually in really fully manifested adrenal crisis or even in the shock, these patients typically have this severe hyponatremia. The potassium levels are increased, usually not very dramatically, like in diabetic ketoacidosis or so, but they are increased. And you often see hypoglycemia. These are three typical features actually for this for the presentation of adrenal crisis. Nothing specific we have, and also take the sample for the cortisol before you start the treatment of hydrocortisone, definitely, because it might, then change your results.
Not hearing.
Zora left, or do we have some technical problem?
No, I'm looking at the questions.
It's okay.
Perfect. I think there was one last question, whether we could give that record to the others, but I think we will upload that in YouTube, right?
Yes, it will be in the EFIM YouTube channel, so you can watch the webinar later once again if you liked it very much.
Okay. Good. Then I would like to thank you very much for both of your very interesting presentations. I think we all learned a lot tonight. And I would also like to thank the audience for coming and participating with the questions. And we will keep you all updated about the next webinars coming from the Young Internists in EFIM.
Thank you. Bye.
Thank you very much, everybody, and have a nice, great Christmas time. Bye.
Bye-bye.
You too. Bye-bye.